2% of Caucasian, a rate much higher in whites than previously thought. Now, defining terms is also very important in PCV. The Asia Pacific Ocular Imaging Society, APOIS, recommended the following consensus terminology. The polypoidal lesion rather than polyp, since we can see a lumen and a dye filling and not a solid lump. Branching neovascular network rather than branching vascular network, as the depth of the lesion is generally agreed to have breached Brooks membrane, exactly where would find a type 1 neovascular membrane and its exudation often respond to vascular endothelial growth factor, antivascular endothelial growth factor, anti-VEGF. So we recommend the term branching neovascular membrane as stated by Dr. Chang. Well, this is important, the diagnostic criteria. Diagnosis of PCV was always posed a challenge because indocyanine green angiography has been the gold standard for the diagnosis. And indocyanine green is invasive, requires special equipment, and it's not available in many hospitals. So this is one of our cases. This is the early indocyanine green. It shows quite clearly. It's fantastic in diagnosing PCV, the polyps, and this is the late stage of the ICG. This is a 77-year-old diabetic patient, hypertensive, rift papillary CNV secondary to PCV. Right in the right eye, there is a PCV also with peripapillary pigment epithelial detachment. Now, I'm going to show you the difference between fluorescein angiography and ICG in diagnosing PCV. This is the fluorescein angiography picture, and this is the ICG. If you can see now, you start to have the leakage, fluorescein leakage, and you can see here the staining of polyps. And as the time goes, you see only here the leakage. It's the hyperfluorescence in fluorescein, but you can see very clearly the polypoidal lesion in ICG. So ICG is really the gold standard in treating, in diagnosing polypoidal choroidal vasculopathy. Well, diagnostic criteria. Let's talk about OCT. This is very important. The APOIS opposed the following signs to differentiate PCV from typical neovascular AMD. Using OCT, three primary signs seen on OCT are a sharp peaked pigment epithelial detachment, which appears as inverted U or thumb-like projection. Second, a ring-like lesions, small lesions under the retinal pigment epithelial, possibly with a hyperreflective center. The first two signs are seen with the OCT, P, ultrasound, a complex shape of retinal pigment epithelium elevation with hyperreflective branching neovascular network. This is better seen with the NFAS OCT. Now, if we look at this case, look at this typical thumb or inverted U shape retinal pigment epithelium. This is characteristic of PCV. And if you look under the retinal pigment epithelium, you see these hyper-reflective small lesions. Also, you can see this sign, I'm going to the double layer sign is quite obvious, and the multiple retinal pigment epithelial detachments. Now, this is an NFAS analysis, shows the hyperreflective branching neovascular network. This is my patient. He came, and this was the NFAS picture at the level of retinal pigment epithelium. And this is when he had recurrence months later. You can see that there is an increased polypoidal lesion on the image on the right-hand side. So this is a very, very important tool to diagnose. I think the OCT and OCTA in particular are very important in diagnosing PCV, and you can depend on them. It's not necessary to use the ICG anymore to diagnose the polypoidal choroidal vasculopathy. The additional signs are complex multilobular pigment epithelial detachment, a double layer sign, as I showed you, which is a split between retinal pigment epithelium and Brooks membrane, often where branching neovascular network component lies, the pachychoroid, which is the dilated halar vessels, and the fluid compartment with prominent subretinal fluid. If you look, this is the multiple retinal pigment epithelial detachment. You can see this is the split double sign over here, and you can see the fluid compartment everywhere, intraretinal, subretinal, and subretinal pigment epithelium. You can see the pachychoroid, quite obvious in this case. You can see the double sign. It's very obvious here, whereas there's a separation between the retinal pigment epithelium and Bruch's membrane. This is an indocyanine green picture. Now, as I said, fluorescein angiography commonly demonstrates an occult type of neovascularization pattern of leakage. Doesn't show that there's a PCV. It has a limited value in the diagnosis of PCV as a choroidal flush limits visualization, as you've seen in this case. This is hypolopoidal choroidal vasculopathy, and this is the fluorescein picture. It shows only leakage that increases with time. This is the same. Now, OCTA is a novel non-invasive imaging technology which enables the detection of vascular flow, blood flow in the retinal and choroidal vasculature without the use of exogenous dye. OCTA seems to be equal or maybe even superior, in my opinion, than the ICG in detecting branching neovascular network. Look at this. This is a case of 75-year-old male patient, hypertensive. He came to me with blurring of vision in his left eye of 1.5 years, has a chronic CSR due to peripapillary PCV. He had 12 Avastin injections without improvement. This is also one characteristic of PCV that does not respond quite well to anti-VEGF, especially Avastin. And you can see the CSR and you can see the lesion over here. It's quite obvious, the lesion, the peripapillary region and the subretinal fluid. Now, this is the OCTA picture. You can, let me show you. This is, you can see here the polypoidal lesion, quite obvious. And while you are moving down, you will see the second lesion, which is the neovascular network, the branching neovascular network. So this is definitely a very important tool for diagnosing of PCV if you don't have ICG. Fundus photography and multicolor imaging. This will help, as I'm going to show you. Multicolor imaging is a novel imaging modality in which images from 3 different wavelengths, the blue, green, infrared, are obtained simultaneously. Polypoidal regions are most clearly seen with the infrared reflectance that appear as a dark gray oval lesion with distinct margins, and the branching neovascular network appear as a mottled gray areas. And you can see this is, you can see the mottled areas here, and you can see the oval gray lesions in these 2 pictures. This is the second eye of the same patient. He has a small PCV under the macular area. Now, what about artificial intelligence? Studies have utilized artificial intelligence in evaluating and diagnosing PCV, and it's somewhat a bit limited up till now. A recent study by Yang et al. Evaluated the feasibility of training artificial intelligence on publicity available at platform diagnosing the PCV using ICGA. 2-step method was used, identification of normal or abnormal ICGA images during the first step, and then diagnosing PCV from abnormal ICGA images during the second step. It was able to diagnose the images, the abnormal images, with accuracy of 100%, to diagnosing PCV with accuracy of 83%, which was comparable to retinal specialists. In conclusion, advances in imaging, including enhanced depth imaging, swift source OCT, and OCTA angiography, have facilitated the diagnosis of PCV. NFAS OCTA provides anatomical information about branching neovascular network. Polyps are clearly defined in cross-sectional OCTA images, so combination of both OCT and FAS and cross-sectional OCTA provides diagnostic criteria that are comparable to ICG. Thank you very much.
Thank you, Dr. Ayman, for this excellent presentation. As usual, is there any question from or comments from any of our colleagues here?
Yes, doctor and my dear friend, congratulations for this great presentation. And for maybe for auditory and for young ophthalmologists, it's very important, I think, to say about that fluorescein angiography was a gold standard up to some time. And now you mention indocyanine green angiography and OCTA.
Yes.
And what do you really prefer? And the second one is, I just saw that you put Avastin 12 injection to your patients. What do you think of other, especially for aflibercept of idea or something? Maybe some of them are Avastin resistance. And what are you doing in that case? And do you use treat and extend, etc.? And thanks again.
Maybe this is a very important question. Now, we used to underdiagnose PCV in the past. Now, if you have a patient that has a big blot of hemorrhage, you have to think of PCV. If you have a patient who has a lot of exudation that are not responded well to anti-VEGF, you have to think of PCV. If you see this reddish oval lesion in the macular area with the exudation, excessive exudation, that's not responding to anti-VEGF, you have to think of PCV. Now, diagnosing PCV was really a problem in the past because, as I said, ICGA was not available in every hospital. And doing just fluorescein shows that this is a neovascular AMD type 1. This is the only thing that you can diagnose from fluorescein angiography. But with the advent of OCT, as I've shown you, there's a lot of signs, and OCTA, you can see clearly the polyps and you can see clearly the branching neovascular network at two different levels, and this is definitely diagnostic of PCV. Yes, sir.
There is any other questions?
Let's
Okay,
take the
yes.
lady here first.
Yeah, please.
I just wanted to know which software you're using for OCT angiography.
Yeah, I agree totally with you. Whenever you have a big blot of hemorrhage, sometimes it's difficult to see things. You have to analyze every photo on its own. You have to, if you have an ICG, this would be helpful. If you don't, you resort to the OCTA and you take it step by step. And definitely, if you are in doubt anyway, the Planet study have shown that using anti-VEGF alone, they were using Eylea against the Eylea with a rescue treatment of PDT, you can start treatment. The treatment is the same. So you can start with your anti-VEGF and you follow on the patient. When the hemorrhage subside a little bit, you can take another photos that can confirm your diagnosis.
For the sake of the time, we can have another at the end, maybe another questions. Can we do it in the end of the meeting?
We can do
please?
that.
Okay.
Thank you very much.
I will introduce my dear friend, Dr. Amin Marashi, and he will give a talk about ENFAS OCT, the lost art. Dr. Amin. So if you can introduce yourself more details.
Hello, I'm Dr. Amin Marashi, retina specialist from Aleppo, Syria. I want to talk about the structural ENFAS OCT. I call it the lost art because it is available in every machine, but it is very underrated. So I'm going to talk now how what it is the ENFAS OCT for those who doesn't know it. ENFAS OCT evaluates structural changes that construct coronal scans for each retinal layer. ENFAS allows ophthalmologists to screen the posterior portal area to locate pathological changes layer by layer. ENFAS OCT is subjected to artifact and has some limitation due to resolution and speed of the OCT machine. That's why it is underrated. So let's take the most famous slabs and how do we read them. The ILM slab technically takes the ILM and the RNFL, so hence it will appear to us as this. It doesn't work. Okay, it will appear at this whitish color, but the fovea and the optic disc will appear more in dark because the absence of the RNFL at this area. The inner plexiform and nuclear layers are very important when you're gonna study the retinal vascular diseases, which appear in this grayish color, and the fovea will appear at the dark due to the absence of those layers at this this area, but the retinal vessels will appear mixture between hyper and hyperreflective. This due to the changes of red blood cells movement. And we have the RPE layer. Obviously, it will appear in white, but those projection from the retinal vessels, that very helpful. We're gonna study the retinal vascular disease, as I'm gonna show examples today. And we have the choroid. Here, the manual segmentation is very important, as we can study the all choroidal layers, or the choriocapillaris, sattler, or Haller's layer, which is extremely important to diagnose pachychoroid, as we can see the diffuse or focal dilatation of the Haller's. So INFAS image processing reveals artifacts, and most popular artifacts are motion blink projection and segmentation artifacts. So the blink artifact will appear as those black lines or bars. The motion artifact will appear as those movement of the retinal vessels or retinal structures. And we have the projection artifact. As you see, this huge MVD, the vascular network has projected on the RPE layer, and we always should correlate our findings with those B-scan overlay, as we see this this new vascular network and this the projections over the RPE. And we have the segmentation artifact. Those machines are almost perfect when we come to normal tissue in segmentation, but when we come to pathologies, they start to segment incorrectly. So as here in this example, where this for IPL INL slab, and we see the RNFL appears in this slab. If we take a look at the segmentation line, it deviates into the RNFL. So we should be very meticulous when we're going to interpret those images, and we should always correlate our findings to the B-scan. So there are several strategies to reduce those artifacts. The patient selection, well-dilated cooperative patients, patient instruction. The patient should understand what we are doing. Technician training. As myself, I don't do those images. My technician already experienced enough and knows those artifacts and knows how to instruct the patients. And we always should compare the INFAS findings with the OCT B-scan overlay. So let's see several pathologies where the INFAS OCT serve the best. For epiretinal membrane, it will appear, we have the pelic ILM slab, which will appear the pelic, and surrounded with those hyporeflective folds on the ILM slab. We have this star folding, which appears as those hyporeflective folds that radiate from the center, and we have the diffuse folding slab. By the way, those are projection artifacts. Not projection, sorry, blink artifacts. The pre-surgical ILM slab is very important to determine the exact location of those epiretinal or vitreomacular abnormalities, and post-surgical we can see how those folds has resolved, and we can see those dimples. Those dimples are signs of ILM being peeled off. And we in a pseudohole, as we all know, the pseudohole is a hole in the epiretinal membrane itself. So we see the hole and we see the smoothness of the epiretinal membrane surrounding it, and we see those hyporeflective folds which simulate somehow a sunflower pattern. And in macular hole, the ILM slab will show us not only the hole sizes and shapes, but it will show us the vitreomacular abnormalities, which is extremely important, especially for peripheral vitreomacular abnormalities when we plan to do pars plana vitrectomy. And the ILM-INL slab will show us the hyporeflective cystic changes surrounded in this pattern with the or separated with the hole itself by this hyperreflective margin, and there is another border for it in advanced stages, and sometimes we can see this hyporeflective changes around it in stage 4. So pre-surgically, we can determine the hole size, and we can see if there is a vitreomacular abnormalities. After the surgery, here we see those dimples that appears about 4 to 12 weeks post-surgery. Those are signs of ILM peel, as during the ILM peeling, we take off the end feet of the molar cells. So we can clearly demonstrate it here. Let's see the retinal vascular diseases. We see the cystic changes in INL ILM slab in the form of hyperreflective cysts. We see hard exudates as hyperreflective. But the main idea here, we can precisely know the location of the macular edema, not like the map. Map can be deceiving sometimes. Here we know the exact structural changes, if it's central or non-central. Another thing, we can manually segment to see the level of the edema, and if we look closely, we can see those medium reflectivity dots, which simulates the leaking microaneurysms. And pre-treatment, we can see the changes on the structure in the structures post-treatment in one glance. And if we have a multiple pathological changes, we can see it. For example, here we see epiretinal membrane. Here we see the location of intraretinal cystic changes. And in cases that are subtle proliferation, we can see those proliferative changes. We see the membrane part of the neovascularization, and as here clearly seen, and here is the ILM slab, we see the fibrovascular membrane. Here we see the vascular network along with non-central cystic changes, and in the RPE and the and the choroidal slab, we see those laser marks. This is the same eye. The INFAS gives me a lot of information. And another important thing, we can diagnose ischemic changes at the level of the IPL INL as due to the atrophy of those INL layer, we see a hyperreflectivity separated by hyperreflective strands, which simulates most of the cases are the retinal vessels. So in retinal vein occlusion, basically the same, but we see this projection, shadow artifact from the retinal hemorrhages, and this is post-treatment. The same we see here, the proliferative changes and the ischemic changes, as I just explained. And in retinal artery occlusion, we see those hyperreflectivity of the retinal layers in the ILM due to the ischemic insult of the tissue, and of course the paracentral acute middle maculopathy. It is very essential to look at the OCT, to the INFAS OCT, as we can see different diffuse and patchy changes, and after the resolution of FAM, we see the ripples, which are the retinal ischemic peripheral perivascular lesions, which may indicate a cardiovascular disease, so that we should refer our patient to an internist. For AMD, basically it shows us the hypertransmission defect on the choroid, which stimulates the geographic atrophy. If we we can delineate the drusens if we go if we segment over the drusens or to the choroid, we can clearly see those hypertransmission defects that simulates geographic atrophy. If we segment over the ISOS junction, we can see the extent of the photoreceptor atrophy, which may give us a clue about the just 2 slides I think I have. No, not more. How it will grow the geographic atrophy. This is tubulation. This is type 2. We see the membranous. And for polypoidal choroidal vasculopathy, it is very diagnostic, as we see here how it appears hyper-reflective inside a medium reflectivity, and around it we can see those branch vascular network, and we can see the signs of pachychoroid. Here we can see the CSCR. I will move fast. The RPE changes, the patterns of pachychoroid and dilated hallers, along with the RPE changes. And here we can substitute find the area of leakage if we do a correct segmentation. So we don't need it fundus fluorescein angiography. This is the vitiliform lesion. It will appear hyperreflective. It can help us to differentiate it from other disease entities. And the last slide for today is how we can see post pars plana vitrectomy, how the photoreceptor layer is damaged due to fluid air exchange. And thank you very much.
Thank you very much, Dr. Amin. Is there any questions for Dr. Amin?
I would like to mention, nice presentation. Thank you for very nice presentation. But I have one question. Do you think, and are you thinking, does it technology working for us, or we are working for technology?
It works for us if we know how to segment correctly and to do correct. If we have the enough experience and how to segment it correctly and to remove the artifacts and to read the main pathology, for example, when they were discussed just now for polypoidal choroidal vasculopathy, it does an excellent job. It may explain to us why we have a reduced vision after successful pars plana vitrectomy, and to diagnose the subtle geographic atrophies. So it needs a bit of patience and knowledge how to deal with those artifacts.
Yes, thank you very much. And may I?
You want to move? Just one question. I mean, yeah, there is a question mark. I think it's a very great job. But do you think we have a time to go all through this? To be honest, yani, or you have someone to give you the report about this one, this first. The second one, now we can compare it. I will compare it like when we are dealing like X-ray, long time back. So we go all through the all small. Someone can explain 100 times or 1 hour talking about X-ray, but within one shot, CT scan can solve our problem. What do you think? In very short, please.
It's like OCT angiography. It's the same principle. Here you see structure. OCT angiography, you see vessels. We waste a lot of time with the OCT angiography just to read the vascular changes. I think the retina is not only vessels, it's structure as well. Neurotissue. Here we can see the changes at the neurotissue. So if we are experienced enough with the OCT angiography, this will be a very easy job.
Thank you.
Yeah, I think it's important. The emphasis is important in some diseases like epiretinal membranes, like PCV, like geographical atrophy. The other diseases you can diagnose it with OCT, but certain diseases it's really very informative. Thank you. Thank you, Amir.
Okay, thank you very much for this discussion. And may I ask for our next lecture, Mr. Jose Gerardo Garcia Aguirre, if I tell.
Very nice,
well.
very nice, yes.
Thank you. With the lecture, visualization and grading of vitreous opacities using dynamic ultrawide far infrared SLO. Here you are.
Thank you very much, and thank you all for being here, and thank you to the organizing committee for the kind invitation. It's a real honor and pleasure to be here. These are my financial disclosures. So vitreous floaters are a bigger problem than we currently recognize. Now, how big is the problem? Some early papers reported the incidence in 3.1 per 100,000 in Sweden. Now, these patients were patients that actually underwent vitrectomy, so the rate is actually quite low. But in a survey done in general population in South Korea, among 603 smartphone users, averaging the 29.5 years, which is quite young, 76% reported vitreous floaters, and 33% reported significant impact in everyday life. And in most, like a conference room that I've been, over 50% of people report seeing floaters. Among you, how many of you see floaters? Yes, and because we are ophthalmologists and retina specialists, you are always looking, for them, right? Yes. Now, this is because PVD, the process of PVD starts actually earlier than we conceptualize. And this is a paper presented by Dr. David Brown in last year's American Academy of Ophthalmology, when he, using a circular, like the retinal nerve fiber layer OCT image around the nerve, you can see early, and you detect early changes that signal the commencement of PVD. And actually, stage B, which is the beginning of PVD, he's showing in 12-year-old patients. So the process of syneresis and posterior vitreous detachment starts a lot earlier than we usually think about it. Now, what's the impact of vitreous floaters in quality of life? Obviously, what we are doing in our office falls really short to evaluate floaters. Snellen visual acuity does not tell us how the patient is seeing. There are other tools like the visual function questionnaire or contrast sensitivity that can give us a clearer picture of what that does. But usually it takes a lot of time, and not all of us are doing these tests in the routine clinical setting. Now, this is a paper that demonstrated how impactful floaters can be. This is a survey done in 311 adults over 21 years. Here the patients were older than the previous survey, 52.9 years, with myodysopsia, that's soft ophthalmologic evaluation, and this was done in Singapore. And patients were willing to sacrifice 1.1 for each 10 years of their life to get rid of the floaters. And they were willing to accept an 11% risk of death and a 7% risk of blindness to get rid of floaters. So this is more important that we are actually considering. Now, one important point here is that the visualizing the vitreous is not easy. It is a structure that evolves to being completely transparent. So there are several ways that we can do this. Obviously, slit lamp examination is one of them, but we can only visualize like a very, very defined vitreous opacity, such as we can see here the Weiss ring. B-scan ultrasound can also be helpful. We can see a Weiss ring here in the ultrasound, but it is very operator dependent, and also it depends a lot on the gain that you are setting when you're doing the study, right? OCT also works. You can see the posterior shadowing of vitreous opacities. However, the field that you are able to see is only maybe 1 or 2 millimeters in front of the retina. If vitreous opacities are more anterior, you are not able to see them. And lastly, confocal infrared SLO, where you can see, where you can see the shadows that are projected over the retina. So in this technique, you are not seeing the vitreous opacities themselves, but the shadow that is being projected on the retina. And this works mainly in the Heidelberg Spectralis device. Now, since last year, I came across this device, the Naidec Mirante, which is a multi-imaging platform that does color fundus photography, wide field photography, FA, ICGA, OCT, OCTA, all in one. And I stumbled upon, I saw that when you are doing ultra-wide field imaging in the infrared preview, vitreous opacity is really, jumped out. So you can see a patient that has a Weiss ring there, and you can see how the vitreous opacities move. And this is just a preview. I mean, the company didn't realize that you could do this kind of imaging. So after seeing some patients and doing some studies with this device, some of my colleagues and I, one of them is my wife actually, we developed a vitreous opacity scale with these findings. And we published this recently in the Journal of Clinical Medicine, and that is the link that you can find the paper. Now, grade 0 would be like this, where no vitreous opacities are seen. This is a very young patient. It's a 24-year-old girl. And as you can see, there are no shadows projected over the retina. Grade 1 would be very diffuse opacities that do not involve the macula. So in the superior part here, you can see some movement of the very peripheral vitreous opacities. This patient is completely asymptomatic. Grade 2 would be diffuse opacities that involve the macula with eye movement. So as you can see, these are like translucent opacities. They are not completely opaque, but they are crossing the macula. And so this patient does have a little bit of symptoms, and you can see the bise ring, floating around over here. Grade 3 is like the first patient that I show you, dense opacities that involve the center of the macula with eye movement, but not on primary gaze. So this patient, only when the eye is moving, sees the floaters. And that's one of the beauties of this technique, that what you're actually seeing, as I said, it's the shadow, not the floater itself, and you can get a clearer picture of exactly what the patient is seeing. Grade number 4 will be dense opacities that involve the center of the macula, both with eye movement and on primary gaze. So this patient is really, really symptomatic, as you can see there, and there's a lot of stuff moving around, as you can see there. And grade 5 will be very dense opacities that involve both without movement and moving, and they are greater than 2 disc diameters in size. And actually this one is like a Japanese koi fish. You can see it there. And this is another patient that has asteroid hyalosis. So opacities are really, really thick. And the patient is very, very symptomatic. So we included 30 eyes of 21 patients. Grade 1, we found grade 1 opacities in 10%, grade 2 in 33.3%, grade 3 in 36.6%, grade 4 in 6.6%, and grade 5 in 13.3%. And the causes of the opacities were mainly PVD, obviously, 63.3%, vitreous syneresis without PVD in 23%, asteroid hyalosis in 10%, and vitreous hemorrhage in 3.3% of patients. Now, all these patients were asked how mild, moderate, or severe their symptoms were, and there was a very positive 0.8 correlation between the opacity grade and the symptoms perceived by the patient. Now, this is not in the study, but obviously we have to talk about vitrectomy for these patients, which is kind of a hot topic. I don't know here in this part of the world, but in Mexico, it's still taboo doing surgery in these patients. It's thought of as a healthy eye, and you're doing surgery in a healthy eye. And for some reason, this is like kind of forbidden. However, this is coming. I mean, we are going to be eventually doing more and more procedures for patients that have vitreous floaters, especially with the advent of multifocal and EDOF IOLs. This is the result of the 2021 ASRS PAT survey. And as you can see here, most of us that answered this survey do not or do just a little of procedures for vitreous floaters. Because as you can see here, some practices are doing 20 to 30 or 30 to 40 or over 40 of all the procedures only for vitreous floaters. So I think this is going to become more common as we go on. This is an example of a patient. This patient had PVD, and so you're going to see the vice ring over here, and also had a very thick opacity just in the center. So this is the vice ring, and this is actually an epiretinal membrane that spontaneously detached, but was very, very bothersome to this patient. And in the next slide, whoop, can we go to the next slide, please? I'm pushing the button, it's not working. So this is the same video that we saw, and can we click on the other video, the second video? Just push play. Thank you. And this is after doing a phaco-vitrectomy. As you can see, this opacity is actually in the posterior capsule, so it's not bothersome for the patient, but all the vitreous opacities are gone. So vitrectomy for symptomatic vitreous opacities has shown to cause subjective improvement of patient symptoms, improved scores in the visual function questionnaire, improved contrast sensitivity, and actually improvement in depression associated to floaters. So, I mean, all of you have some patients, not a lot, but some patients that are really, really depressed because of their floaters. So in conclusion, ultra-wide field infrared confocal SLO is a very useful tool to visualize the shadows that vitreous floaters project on the retina. We are proposing a scale of 5 grades, or 6 if you consider grade 0, to classify these floaters, and we are still lacking a very good way to measure these things. The opacity grade was positively correlated to symptoms, and this is actually a very useful tool to educate patients and families and to guide management. And I just want to thank Professor Hakan for the invitation, and I'm open for questions. Thank you very much.
Jose, that was an excellent talk. Thank you very much. We tend to undermine the floaters, and it's really a big problem. As you said, we don't do vitrectomies, and I always tell my patient it's like killing a fly on the wall using a gun. This is not the way to do it. But I was faced with just a few patients who insisted on doing the surgery in spite of anything because their quality of life was miserable. Now, my question to you, when do you do vitrectomy in those patients? And my second question is, all of us, they tend to do posterior hyaloid detachment. Do you do that or you don't?
So all of those are really good questions, and I don't think we still have a good answer yet. And by good answer, I mean something that's backed up by evidence. So I don't think that you should directly go to surgery in a patient that just started seeing floaters, because most of them will be gone after some months. So you have to wait and see what happens, see how the patient is feeling. Also, I will not do surgery in a patient that has a lot of symptoms, but when I do this study, only has a little bit of floaters, because I know that after surgery there's not going to be a lot of change. So I have to see objectively that there are floaters, there's shadows on the retina before I do the surgery. Now, to answer the next question, I think in these patients you have to do a PVD, because if you are not, then eventually he or she will get a PVD, and then the floaters will go back. So I think it's one of the things that you have to do. Obviously, there's a risk because some of these are young patients that you may cause a retinal tear.
I have one patient in which I did a PVD in one eye, and I didn't do that on the other eye. In fact, doing a PVD on that first eye was really a very, very difficult job to do. Those patients are young, and the posterior hyaloid is very attached. It's very difficult to remove it, and sometimes you might cause problems. So I did it in the second eye, and he was happy in the second eye, the same as with the first eye. So I'm not tending to separate the posterior hyaloid anymore in these cases. Definitely, theoretically, you still have some vitreous on the retina, and the pathology might recur. But I feel that tempting to remove the posterior hyaloid in those patients might cause some harm.
Now, I think that we are. This is taboo. We are as a group, we are against this. But this is, for me, it's the same as having, for example, refractive IOL implantation. I mean, if you do this in a high myope, then you're going to increase the risk of retinal detachment, and the patient knows this. And still, patients are really grateful. Obviously, the ones that get a detachment, they are not. But I mean, they have. If they know the risks and want to go through with the procedure, I think we should offer this to them. Dr. Barbara Parolin from Italy once stated this very clear to me, that patients with floaters is like looking through a fishing net. So you can see 20/20 through the net, but still it is very bothersome. And the only person that knows how he or she sees is the patient himself. So I think eventually we're going to open our minds to this, and there are some efforts of getting rid of the floaters without vitrectomy. YAG laser is not a very good idea because the amount of energy is very high, but it's started to be explored using a femtosecond laser. So maybe in the not so far future, we retina specialists are going to start buying femtosecond lasers. I don't know.
Thank you very much. There is one question actually. You open. I am here.
Oh yes.
Actually, you open the vitreolysis with YAG laser. I think there is a lot of advantage, or I mean, they are improving on this. How do you find this one? I mean, it's
so that I have never done YAG vitreolysis. I don't think it is done in Mexico, and also well, we Mexico we have a very heavy influence from the United States, and in the United States it's not performed in a lot of places. In Florida there are some spots, and in Bascom Palmer they do get to see all the complications. There are complications, potential complications in the lens causing cataract, or what we fear the most is a retinotomy or a subretinal hemorrhage because of a very posterior
I mean,
YAG
now
laser?
they are having a very specialized machine to use for vitreolysis, not the YAG, the ordinary YAG. And they are having many study about this one. And especially, I mean, if you are to expose your patient to a vitrectomy, which is a very big surgery, in comparison with one shot, if you are, there is, I mean, a different type. You will not use those, they are very close to the macula, and you do a vitreolysis. Some of them, they are getting a very good benefit. I mean, it is a debatable.
I mean, we could spend a lot of time talking about this.
Yeah.
What I don't like about YAG laser is that you're actually not getting rid of the floaters. You're just making one big floater into several small floaters, and maybe sending it to the periphery.
I have
right?
the same experience as yours. It has a limited use, except if you have only a single opacity that you tackle. But when you have multiple opacities, you have opacities near the macula, it's not working. Thank you very much.
Thank you.
Thank you very much, Jose. And we'll move to our next speaker, Dr. Susanna Teixeira. And Dr. Susanna will be talking to us about the role of fluorescein angiography and retinopathy of prematurity.
Good morning, everybody. I'm Susanna Teixeira, ophthalmic consultant in Retina from Portugal. Well, so now we are going to dive into childhood, into before childhood, so in prematurity. We all know that ROP diagnosis is with ophthalmoscope, indirect ophthalmoscope. But nowadays, we have wide field cameras that allow us to perform fluorescein angiography. And it's quite nice. We can do it in the NICU safely under sedation. And usually we don't have local or systemic complications, but we always have prepared medication for anaphylactic shock. That's very important. That's the image we usually see with indirect ophthalmoscope, and that's the usual image that always guides us. But when we use angiography, boom, we can see all the retina and all the details of what's happening in those vessels, because retinopathy of prematurity is a vessel disease. So we can use this angiography to look exactly to the activity of the disease. So we can see the extension, we can see the severity of the disease, because even in the anterior segment, in the most worst diseases, we have fluorescein appearing, and we can see the extension posteriorly of the most hard diseases. We even can see the patency of the posterior hyalid artery, so we know the severity of the disease. And we can go home, sit, and analyze all the images quietly after making the angiography. So you can see the capillaries, you can see how the vascularization behaves. And even in the follow-up, we can try to know what's happening. I mean, we have retinal hemorrhage, but we can see that there is no leakage, so there is no active disease. And I use it quite often in the follow-up. So we have proliferation, and suddenly we don't have active disease. It's just a residue of the disease, the regression of the first disease. And we can find sometimes occult neovessels, what's very interesting studying. Oh, this is not going on. The next slide, okay. We began to use most often the angiography after the use of anti-VEGF therapy. And after using the anti-VEGF therapy, we could begin to find some funny things in the retina, and that's why we do quite often the angiography. So from the posterior to the anterior, in the choroid, you can see in some of the most aggressive ROP, you can see a patchy choroidal filling that it's not normal in the other babies. And in the retina vessels, we can see most of the times a tortuosity that goes along the life of the baby. And we can see some funny things like vascular shunting and anomalous dichotomy of the vessels. You can see all the differences and all the anomalous dichotomies of the vessels on the periphery and dropout of capillaries. And you can see vein-to-vein shunting, not only artery-to-vein shunting, and all the funny things in the limit from the vascular to the vascular retina, like the vessels are cutted and you have ischemia behind, posterior to the limitation of the vascularity. You also can see these tangled vessels, so like the vascularization of the retina is confused after the anti-VEGF, and when all the retina is vascularized for the 40, 60 weeks post-menstrual age, you can see like the fingers, the vessels are stretched. That's a very common finding after a complete vascularization of the retina after the injection of anti-VEGF. But also in the macula, we can see funny things like the vessels crossing the macula, so you don't have a completely vascular macula, or you see pinpoints that we still don't know what that means. We are still learning from doing this angiography. But the most interesting is that even in babies that didn't have anti-VEGF injection but had a spontaneous regressed ROP, we can find the same findings. What make us wonder that perhaps these findings are not typical of the anti-VEGF injection, but because of the disease itself. And our problems with the anti-VEGF injection are the peripheral avascular retina. And that's a big problem because we think that peripheral avascular area, some of the babies that have injected anti-VEGF has quite often this peripheral vascular area, and even the babies that had regressed spontaneous ROPF, this peripheral aggressive vascular area, this is, nobody knows really what's this, the function and what's happening in this area. So we all think that it's this avascular area that can provoke recurrent disease. So you use angiography, fluorescein angiography, to study the interface between the vascularized and the avascular retina. Most of the babies have acquired non-active vascularity in this area. As you can see here, so we have a vascular area, and in the interface we have no problem. But in some of the babies, we have this kind of activity at 7 weeks post-menstrual age. So those are the babies that worry us and are in risk of have a recurrent disease. As you can see here, also, a vascular area, and you have fluorescein leakage here. So we try to understand if those are the babies that will have recurrent disease. But even in the babies that we laser the avascular area, that we can do it to prevent the recurrent disease, even in those babies, we also have this leakage at 1 year post-menstrual age, and some occult neovessels. What makes us wonder what if we should do laser to all those babies or just follow up on laser those that are in most risk to recur. We use also fluorescein angiography to see the recurrence pattern, although the recurrence is diagnosed only with ophthalmoscopy. But angiography will help us to understand the pattern of the recurrence, if it is just in the front or in both the first seat of ROP and the new advanced front. But what helps, or where it helps us most, the angiography, is in detecting and characterizing the atypical ROP. And we all know that nowadays, with very little babies, we can have some kind of different presentations of ROP, like the Roper, like the posterior fever, and like oxygen-induced ROP. So all those entities are in premature babies and can mimic retinopathy of prematurity. So this is a baby that has some kind of aggressive posterior ROP, but also seems like an oxygen-induced ROP, and at 1 year it behaved like a fever. So it's very complex to study those complex or different babies. This one also came to us like an ROP, but we suddenly see those vessels, as you can see, pumping into the vitreous. So it was not completely an ROP. So here it seems like an ROP, but here it seems like a different kind of disease. So we did laser, as you can see. And in the other eye, it was even the most complex because it was a premature baby with some kind of retinopathy, but the vessels were coming into the vitreous, so it could be some kind of difficulties in the posterior fetal vessels or in the eye. So also, the future bring us some very interesting things like artificial intelligence that is using the images of fluorescein angiography to try to make a pattern to diagnose plus disease and to diagnose only by artificial intelligence the stages of retinopathy of prematurity. So, fluorescein angiography is safe in those premature babies. Help us always. It's a continuous process of understanding the physiopathology of ROP, improves very much the visualization of the vessels and our decision to treat the baby. Helps to characterize different presentations. What's this? But I have more questions than answers, so we are always learning a lot about when we are doing fluorescein angiography in children. And, yes. And we still have a lot of questions, meaningly, when should we do, at what postmenstrual age should we perform the angiography, and what should be the best decision after that procedure? So it's an open, wide world, not yet with definite questions. So we are making history for now. Thank you.
Thank you very much. It is a very great and very scientific lecture, because every ophthalmologist who ever saw retinopathy of prematurity has a lot of questions. And few. That's something really.
It's a ghost. It's a ghost.
Okay. Okay, and thanks again. And I would like to ask you two questions. The first, when you really time to make decision to perform fluorescein angiography, what is the real indication if you could see with indirect ophthalmoscopy? What is the reason for that?
The decision to make the treatment is under indirect ophthalmoscopy. Period.
Okay, but why?
But when I have doubts, and my doubts are not for the decision of to make or not to make the treatment, but to know the extension of the disease. So if I have opportunity, I would like to do angiography to all the children, but I cannot. It's a bit difficult to me to make angiography and injection on the same day because I'm afraid of the endophthalmitis, So I perform angiography the day before, so it makes that the baby comes from another city, so have to stay 1 day. What do I mean? I don't perform angiography absolutely on the first time of the acute phases of ROP. We usually perform angiography at 70 weeks postmenstrual age. What that means? When all the retina was vascularized, and it's the window of recurrent disease. So if the disease has to recur, it's until 70 weeks of age. So from that age on, all the retina should be vascularized. And then we have the peripheral vascular area. So I perform to all peripheral vascular areas after 70 weeks postmenstrual, so 70 postmenstrual age, to see this interface between the vascularized and non-vascularized retina, and I decide what to do. So, if it has no activity, I follow up the kid 6 months, then 1 year. If there is some kind of activity, I have two hypotheses. If the parents agree to bring the child to me periodically in order that I can see how that vessels will go on, I prefer to do it because it's better for the baby not to have laser. And I learn. We all learn from this. Now, if the parents don't come to me, if they say, no, I cannot go to you all those 15 month, so I perform the laser of that avascular area. So it's the 70
Laser
weeks.
before the anti-VEGF or you first use?
No, you do anti-VEGF, you allow
Yeah.
the vessels to grow, everything calms down until the 70 weeks of age. So after that, you have a peripheral avascular area that is like in the old maps, that you have the earth, the sea, and that was a monster. After the sea, there was nothing, it was monsters. So we have the retina, and we have a monster that we still don't know what means. That is the peripheral avascular area. And that peripheral avascular area in the States at 60 weeks of postmenstrual age, if the baby has that peripheral avascular area, they do laser. That's a school.
Yeah, I see.
I prefer, because I prefer to study. If the parents can bring back the baby to me, I prefer to study that avascular area and learn what really that means. But if they cannot, I perform laser because I'm afraid of the recurrence that I cannot see.
Okay. And excuse me, in which position you put the baby during fluorescein angiography?
It's laying down like that. So the baby is inside the incubator. If he's very tiny, he's inside the incubator. Sometimes it's still under artificial ventilation. And you have the rat cam, it's quite heavy. The nurse, the baby is dilated, both blepharostatus in both eyes at the same time. The nurse injects the fluorescein, then a bolus of physiologic serum, and I perform to film. I begin to film. When it comes from one eye, so when the fluorescein comes to one eye, I film that eye, then I go to the other one because I want the initial times. Then I go to the other eye again, so I perform this until 2 minutes. Then because the rat can has not more space to moving, I stop the movie and begin to shut until 8 minutes to be sure that how behaves that fluorescence. So that's how I usually perform. Then I go to the video and take frame by frame and then gather everything and then I study all the images.
Susanna,
That's how we do it.
just in short, sometimes we confuse the diagnosis of retinopathy of prematurity with fever.
With fever.
Which is familial exudative vitreomaculopathy. Now, is this technique helpful in differentiating both and how? Shortly, please.
Yes, shortly. Well, retinopathy of prematurity is a peripheral disease. Of course, you have plus disease, but the vascularity is peripheral. The main issue is that in fever, it's most near the disc. You can have like some kind of proliferation near the disc along the retina, and you can have very much posterior avascular areas, ischemia posterior in the normal vascularized retina. So that's the most important. Then you have some blunt vessels, you have some prune vessels that can be more for fever, but I see it quite often in retinopathy of prematurity. That's why.
The problem is that clinically you can confuse both. But
it's very easy.
Is
but
angiography helpful?
Yes, because you have a most posterior, most near the optic disc in fever. That's why when it proliferates, it drags all the retina to the optic disc, like in the first baby I show. So, but most of the times you have very common, mostly in ROP, in aggressive ROP, you have very common findings in the aggressive ROP that are like fever. So I think if it genetically make a genetic of the aggressive ROP, we would find for sure some kind of fever genetic in those babies. Thank you. Thank you for the question.
Thank you very much, Dr. Suzanne, for this nice discussion and presentation as usual. We will move to our next speaker, Dr. Nasreen. She is going to talk about multimodal imaging findings and management of vitreoretinal lymphoma. And if there is any question, we can keep it to the end if we have for any speakers. Thank you.
Thank you. I will talk about the use and the help of multimodal imaging finding for the diagnosis of vitreoretinal lymphoma. So primary vitreoretinal lymphoma is the most common malignant uveitis masculine syndrome, and the diagnosis of this condition is challenging. So multimodal imaging is a valuable tool for the diagnosis of primary vitreoretinal lymphoma. So here we are describing multimodal imaging finding in the case series of patients. It was a retrospective case series of 4 patients we have seen in our department in Monastir, Tunisia. For all of these patients, we have performed the ophthalmic examination, fundus photography, fundus autofluorescence, fluorescein angiography, and OCT angiography and OCT. And all of these patients had vitreous biopsy for the diagnosis confirmation and brain magnetic resonance imaging. So we had 4 patients, 2 female and 2 male patients with a mean age of 68 years. The mean initial visual acuity was 20/32, and all of these patients had visual blurring as a symptom of this condition. So in clinical examination, we had in all of these cases a sort of mild anterior chamber inflammation. It has in 2 cases there was granulomatous keratic precipitates, and in 1 cases we had hypertensive anterior uveitis. The most important finding in this patient was the vitreous haze, which was present in all cases. In 2 cases, we had vitreous clamps. In 1 case, exudative retinal detachment. And I think the most common and the most important finding was this cream-colored subretinal deposit, which may be different in size, in location, and number. And these deposits or this lesion, subretinal lesion, are characteristic and pathognomonic of vitreoretinal lymphoma. Fundus autofluorescence finding was very variable with a different pattern. We had hyper autofluorescence subretinal lesion, like in this case. Other cases had a mixed pattern with hyper autofluorescence and hypo autofluorescent lesion. In some cases, we had a granular aspect with a leopard aspect, and in other cases, we had a sectorial hypo autofluorescent lesion. Fluorescent angiography showed a hypofluorescent subretinal lesion in the case of large deposit, clinically visible. Hypofluorescent lesion, as in these cases, with a leopard spot appearance, a granular pattern in other cases, and we had some cases of retinal vasculitis and late staining, as in this case. In 1 case, ECG angiography showed a large hypofluorescent lesion, as we see here. And the most important finding, I think, in vitreoretinal lymphoma is the OCT aspect, which is characteristic and pathognomonic. This hyperreflective subretinal lesion between the RPE and the Bruch membrane, when you have this deposit seen clinically, are hyper reflective, and between the RPE and the Bruch membrane, these lesions are very characteristic of vitreoretinal lymphoma. We can also find some RPE clumping, some outer retinal ellipsoid irregularity. In some cases, we have epiretinal membrane, intraretinal fluid, and even exudative retinal detachment. OCT angiography showed multiple hyper-intense spots in the deep retinal plexus, and in the choriocapillary slab we show large area of no flow signal. So in all of those cases, we do brain MRI, which was normal in all cases. Vitreous cytology with vitreous tap revealed atypical monocular cells in 3 or 4 cases. In 1 case, it was negative. So we performed diagnostic vitrectomy with retinal biopsy, and the diagnosis was confirmed. Just to stress on something, in doing vitreal tap, we have to take undiluted vitreous samples before making the infusion on, and we have to use a lower cut rate because the vitreous, the lymphoma cell are very rare and fragile, and we have to take the vitreous tap rapidly to the lab. So all of the patients were referred to oncology department for management and for treatment. To conclude, the diagnosis of primary vitreoretinal lymphoma is challenging, and a close coordination is necessary for making diagnosis between the ophthalmologist and cytologist. Multimodal imaging is helpful to identify lesions that raise the level of suspicion of primary vitreal lymphoma, which potentially trigger a defined diagnosis procedure. Thank you for your attention.
Thank you very much, Dr. Nisreen, this excellent presentation and nice diagnosis. And if there is any question or comment from any other our colleagues, Dr.
I have a quick question for Serene. Tell me, when do you expect lymphoma? You know, sometimes the patient comes to you with posterior uveitis.
Yes.
That's not responding. So when do you start to suspect lymphoma in those patients?
Thank you for the important remark. I think we have the first thing to suspect vitreoretinal lymphoma in elderly patient. When we have an elderly patient who is coming for a diagnosis of uveitis, we suspect lymphoma. First thing. The second thing, when you have the multimodal imaging is very helpful for diagnosis. I think the OCT, when we have this subretinal lesion, this undulation of the RPE with hyperreflective lesion, whether in periphery or in the posterior pole, it's very pathognomonic feature associated with vitritis or anterior segment inflammation in an elderly patient. We have to do MRI and vitreous tap. And in some cases, this patient respond to corticosteroid therapy, exactly, but there is a recurrence, and when we do vitreous tap, there is lymphoma cells.
Very important point that patients with lymphoma, if you give Ozordex, the
There
vision
is-
will improve, the sleep will improve, but it will recur aggressively. So keep it in mind. You think blood test will help? Any blood test?
I don't think.
Is it a secondary or primary lesion usually?
It's a primary vitreoretinal lymphoma, primary.
Primary. There is any source, sometimes you will find it as a secondary, so that's Dr. Ayman asked you, maybe we can find.
Choroidal metastases are
Yeah, as a
different.
myth, yeah.
Yes, this is a mass in the choroid that's not, it's not the same clinical picture.
You have any other questions?
There are quite a few patients of primary intraocular lymphoma in one differentiating feature that I've seen in my experience perhaps, and I'd love to know your comment on this, is that they have vitritis, but they don't have a lot of macular edema. So there's not a lot of intraretinal cystic spaces as you might expect from a case of uveitis. So that's also one thing pointing towards primary vitreoretinal lymphoma.
Yes, I agree with you. I think in these 4 cases, only one had macular edema with vasculitis. But in the other cases, there was no vasculitis, no macular leakage.
Thank you, Serene. That was excellent.
Thank you very much. And for this session, the last one, and we are expecting a lot of, that's Mr. Amir Arain, quantified retinal vessel density in posterior uveitis using spectral domain optical coherence tomography angiography. Wow. We will see.
Bismillah ar-Rahman ar-Rahim. I'm Dr. Amir from CMH Peshawar, and today I'm going to discuss my study, quantifying retinal vessel disease in posterior uveitis using spectral domain OCT. It was a pilot study which I have conducted at Combined Military Hospital Peshawar. Macular abnormalities, they are common and in uveitis patients. Blood flow to the posterior ciliary arteries and choroids are decreased in uveitis. Inflammatory mediators are released, and they cause macular edema, retinal ischemia, and neovascularization. Several researchers have revealed that OCT angio can provide quantitative analysis of uveitis. Coca et al. Found that retinal vessel disease, which will be labeled as VD in my further presentation, decreases in Behçet disease. Liang et al. Found that deep vessel density was lower in VKH disease and that deep BD is associated with visual outcome. So in my study, the study question was that is there any difference in macular vessel density between uveitis eye and healthy eyes? In this study, I used spectral domain OCT, RS3000 Retina Scan Advanced 2, NIDEC, Japan, to quantitatively assess the vessel density in patients of posterior uveitis. It was a cross-sectional observational case series on healthy and uveitis patients, all adults at VR department CMH Peshawar from 1st March 2022 to 31st August 2022. Approval from hospital ethical committee was taken. Written informed consent was taken from all patients. All the patients who were diagnosed either unilateral or bilateral uveitis, they were included. But subjects who were unable to fixate or had significant media opacities, those who have diabetic retinopathy, retinal vascular occlusion, glaucoma, age-related macular degenerations, or those patients with uveitis who were having CMOs, they were also excluded. Then healthy subjects with no ocular disease other than refractive error were recruited as controls. Image qualities 6 or less, they were also excluded. And patients with large or diffuse floaters or significant segmentation error or motion artifacts, they were also excluded. All uveitis patients were evaluated with complete history, ocular examination, imaging, and appropriate laboratory studies. And all patients were imaged by 3 mm by 3 mm scan centered on fovea by RS3000 OCT angioretina. This machine has got a built-in software which do the segmentation and then do the vessel density. Now, vessel density is the amount of the vessels present in the retina, and it is measured in 2 layers, superficial capillary plexus and deep capillary plexus. Now, superficial capillary plexus was defined as from ILM to 10 micrometer above the internal plexiform layer. That slab was for the superficial capillary plexus. And the deep capillary plexus was defined as 10 micrometer above IPL to 10 micrometer below the OPL. Underneath it is the outer retina, which is supposed to be avascular. Underneath is the choriocapillaris, and underneath is the choroid. Then. All quantitative measures were reported with mean standard deviation with 95% confidence interval, and p-value less than 0.05 was accepted as statistically significant. In this pilot study, the total number of patients was 51. 31 patients were 51 patients, out of them 30 are control. And number of uveitis patients in this study were 21, and total number of uveitic eyes were 32. Now, the results shows that statistically significant lower vessel density in superficial capillary plexus and deep capillary plexus of uveitis eyes compared to the healthy eyes was observed. Here, it is important to note that result of no two machines can be comparable. Different machines have got different measurement units and softwares, so the results of different machines are always different. If you have to compare the results, it has to be on the same machine. One of my study on vessel density I've conducted when I was in Armed Force Institute of Ophthalmology, AFIO. It was on the retinal venous occlusion, and it was studied in Pakistan Armed Force Medical Journal in May 2022. There we conducted the study on AngioView system, and the vessel density units were in percentage, whereas in RS3000, the vessel density units are per millimeter. So there is a vast difference. The results were comparable in healthy and uveitic eyes in age and gender. This is the scan of RS3000 of a healthy patient. This one is the color-coded map. The cool colors are shown as a place where there is low vessel density, no vessels. So you can see in phase, there are no vessels. But wherever there are vessels, it is shown with the warm colors. Thank you, sir. So it is shown with the warm colors. And this RS3000, it shows 7 different areas along with a B scan. This is OCT B scan. This is the superficial capillary plexus. Its software automatically gave a color code to the phase. This is the deep capillary plexus. Phase is also visible over here. This is the outer retina, which is supposed to be avascular. Then the choriocapillaris slab. And this one is the outer retina choriocapillaris slab, which is the combination of these two. And this slab is used as a screening tool for AMD in OCT angios. And then the choroid. It also shows vitreous. If there is some vascularization, it will be shown over here. Then it elaborates the phase in quite detail. Phase area is shown in millimeter per square. Then the perimeter of the phase is shown, circularity. Then the grid vessel chart is shown in the millimeter per millimeter. This unit, I didn't find this unit in any of the international studies, because all the studies which were done, they were showing the vessel density in percentages. My previous study had also shown the vessel density in percentages. But in this hospital, we have got this machine, and it shows the vessel density in per millimeter. Moreover, this is the ETDRS sector vessel density chart. Now, generally, this central point is, the size of this central area is 1 millimeter, and the inner circle is 3 mm and the outer is 6 mm. But in this RS3000, the inner is 0.5, the inner area, and this area is 1.5, and the outer is 3 mm. So this whole area, it shows parafoveal vessel density. So these are the differences in machines. So whenever you are seeing these vessel densities, please do see what are the units that they are showing, and because this is, there is a, my understanding is that this is because of the patent. One company acquires that patent, to other company cannot follow the exact protocol what the other company is doing. So in AngioView, these numbers, they were around like in 45, 50%, but in RS3000, these values were like in 13, 14 or 15. So this is a great difference. So if you see something from AngioView system, you cannot compare it with RS3000 NIDEC. But my point of concern is that previously what we used to do FFAs for uveitis to see the leakage, but now this is one of my patient of uveitis, and in this you can see there is no CMO. I have excluded those with CMOs because once the macular edema or cystic spaces arises, artifactually the vessel density decreases. But in this case, you can see that there are many areas which are having cool colors, so the vessel density is decreased. This is the superficial capillary plexus. You can see that in superficial capillary plexus also you can see ischemic areas, areas of no flow. Now this is what we used to see in FFA also. So what is added by doing OCT angio? By OCT angio, we are adding these figures. Now we can objectively measure in which area how much vessel density is present, and that these figures we can follow, we can repeat these OCT angio scans. No fluorescein dye or no dye is required to repeat this test. It's just a simple test, and monitoring the disease is very easier by these figures rather than observing them. Now this would be the picture which we would see in FFA, and this is definitely the deep vascular plexus is not visible as clearly in FFA as we see in OCT angio deep capillary plexus, the second slab. So though in the in the color coded map it is also very obvious that in this patient the vascularity, the vessel density has decreased, but in this ETDRS chart and in this grid vessel density chart, then the whole inner and outer numbers which are shown below, it has quantified the vessel densities which can be used in future to monitor the progression of disease, provided you do it on the same machine. So that was the question for which I conducted this research and found out that there is a significant difference, as in previously you can see these numbers. This is a normal patient. And this is the uveitis patient with reduced vessel density. These numbers are reduced. The point is that these reduced numbers, they are not to be compared with the normal patients, because so far there is no data available on, I searched a lot, but I didn't found any normative data of NIDEC. But in the same patient, we can compare our treatment and the disease progression by repeating the same test. Now quantitative analysis of vessel density in healthy and uveitic eye, once they were compared statistically by the statistics, it has shown that both in superficial vessel density and deep vessel density, the vessel density in normal and uveitic eyes, it has got a statistically significant difference. So this test can be used as a test between the normal and uveitic patients as compared from our study also. Our study is comparable with international studies, though very few studies are done on this topic so far. Shen et al. Concluded that superficial capillary plexus and deep capillary plexus vessel density in autoimmune uveitis is significantly lower than the normal controls, and our study was comparable with his study. Moreover, Cyril, he has published his article in 2022, and he found out that macular vessel density in inactive ocular sarcoidosis, he concluded that deep vessel density, parafoveal and perifoveal vessel density are lower in ocular sarcoidosis. So our studies also showed the lower vessel densities in uveitis patient, though I didn't mention the causes in my study. But our study has got comparable results with the international studies. Now I'll come to the comparison of FFA and OCT angio. In FFA, leakage is a very useful feature for assessing potential uveitis activity that we have been utilizing since decades. OCT, which is a new modality, it cannot detect leakage, but it can describe changes in the blood vessel density of different layers of retina. Results indicate that OCT angio may be used to quantitatively measure the degree of intraocular inflammation with the same machine. So with this, I conclude by saying that superficial capillary plexus and deep capillary plexus vascular density may be used as a quantifiable factor while managing cases of posterior uveitis. Vessel density in superficial capillary plexus and deep capillary plexus may be used in monitoring of the disease activity. However, further research with more variables and more sample size should be done in our setup for further exploration of this domain. The limitation of my study was also the limited number of patients which I had for past 1 year. So I just could find these 21 patients out of these inclusion-exclusion criteria. But still I was able to find something valuable to present to the prestigious, my fellow ophthalmologist here. I thank you very much for your patient listening.
Thank you, Dr. Amish. By this, we conclude our session. And before that, I want to ask speakers not to leave. We want to take a photo. And I want to definitely thank Dr. Hussein Khagan and the organizing committee for this beautiful invitation. Pakistan is a beautiful country with an excellent culture and beautiful population. Thank you very much. I will leave now the microphone with my colleague, Dr. Amri. Questions regarding the session.
First of all, I would like to thank all speakers for their excellent presentation and demonstration. We are sorry, please. I don't know if there is any question to Dr. Amrin for his presentation please.
This was my second study which I have conducted on vascular density. My previous study was about retinal vein occlusions that included central retinal vein and branch retinal vein occlusion. In that we included those patients who had CMOs. So the vessel density was initially very less. It was like 30%. The normal was 45% on an average, and in those patients it was 30%. Once we injected Avastin, so it was a long study, we injected 3 Avastins, the edema reduced, the vision improved, but the vessel density further deteriorated. So that was the finding which was astonishing for us, that we didn't expect that this ischemia was further increasing. So it further increased, and it went from 30 to 25, and with further injections, though the edema was reducing.
Maybe I think, Doctor, your study now just to demonstrate, I think, is there is a change in the just the density. Maybe the next study for him to see what is the result, why it's low dense rather than it's become maybe hyperdense as you suggest. I don't know, maybe it will be very difficult now to explain. Maybe after a long...
Excuse me, may I mention? May I mention?
Vascular Thank you very much.
Okay.
I want to thank you again for your attendance, and I hope this session was fruitful for all of you.
Yes,
Can I ask the speakers to come for a
we can conclude this session.
memorial photo?